My name is Keith Barnes, and I am a registered respiratory therapist. The topic of this course is Analyzing and Interpreting Arterial Blood Gases. It is approved by the AARC for 1.5 credit hours. Here are your learning objectives for this course. When you are finished here, you will be able to describe collection methods for an arterial blood gas, discuss avoidance strategies for pre-analytical errors, list the process steps for ABG analysis, discuss the causes of metabolic acidosis and alkalosis, discuss the causes of respiratory acidosis and alkalosis, identify the role of ABG analysis with mechanical ventilation. Yes, there will be math. By the way, when my friend Joe Lewis, the respiratory coach from YouTube, teaches classes for us, he tells me his ultimate goal is to teach me, Keith Barnes, at least one or two new things. He feels that if he can do that, then he should be teaching our guests at least 3 or 4 things. I know a lot of the information in this course you should be familiar with, but hopefully I can teach you at least 1 or 2 new things. Collecting an ABG needs to be done correctly. I'm going to describe the collection using the radial artery on an adult as it's the most common. You could also use the brachial or femoral artery. Other collection options would be umbilical artery for newborns, capillary samples and heel sticks on infants, and arterial or pulmonary artery lines. Did you know that there is software available that converts venous samples into arterial with an accuracy of about 97%? This software is called VTAC by Roche. So, venous samples are also an option. The most surprising thing about this is that they named their software VTAC. The VTAC I am familiar with can kill you. Let's go through the steps to draw blood gas. First, you'll verify you have a valid order. If you put a nasal cannula on a patient without an order, it's probably not a big deal, although oxygen is technically a drug. With an ABG, you are actually puncturing the patient's skin, and it is a big deal. Gather the needed supplies, introduce yourself, verify the patient's identity, obtain clinical data that's required. At a minimum, it will be SAT, temp, and FiO2 they are on. This might also mean ventilator settings. Perform a modified Allen's test. When they modified the Allen's test, they made it better. When performing this test, you occlude both the ulnar and radial artery and then release the ulnar artery. Once the ulnar artery is released, the hand should pink up again. This verifies collateral blood flow just in case you blow the radial artery. If it doesn't pink up again, find another artery to draw from. Palpate the radial artery. Clean the puncture site with an alcohol swab. Be aware some patients are allergic to alcohol. I have run into it. Pull the plunger back to the recommended collection amount. I use 0.6 milliliters for adults. Insert the needle with bevel up at a 45-degree angle. Once you see blood filling the syringe, stop inserting it. Hold until you have collected the correct amount of blood. Withdraw the needle and hold pressure for 3 to 5 minutes, or for as long as it takes to stop the bleeding. If the patient is on anticoagulant therapy, it may take longer. Never recap a needle. The most likely way for you to get an accidental needle stick is recapping a needle. I'm willing to bet that there are signs posted all over your facility reminding you of this. Remove the needle using a safety device. At my hospital, our kits either have a red cap you stick the needle in before removing it, or a plastic cap that flips over the needle. Either way, you're safe. Gently tap the syringe and remove any air bubbles. Remember, bubbles in the syringe are room air. Room air has almost no CO2 and a PO2 of about 160 millimeters of mercury at sea level. This means air bubbles, if not removed within 2 minutes, will cause a rise in oxygen levels and a decrease in CO2 levels. Mix the sample and label. Transport the blood to the blood gas analyzer. The blood needs to be transported in a biohazard bag, not a cup of ice. Follow your facility's policy on icing a sample, but the book answer is 30 minutes. If you can process the sample within 30 minutes, it doesn't need to be iced. However, the same reference that stated remove air within 2 minutes also states to ice if not analyzed within 10 minutes. My facility's policy is to always ice. Follow your department policy. Factors that influence results. Room air at sea level has a PO2 of about 160 and a CO2 of 0. Air bubbles therefore will cause the PO2 to rise and the CO2 to fall. These should be gently removed immediately after collection. Delay will allow leukocytes to consume some of the oxygen and return a falsely low number. Hypo or hyperthermia can affect the results, so body temperature should be recorded. Before inserting the blood into the analyzer, verify it's the right patient, right blood. Does the order match the name on the syringe? While always important, it's most important if you didn't draw the blood yourself. This is probably a good spot to discuss calibration of the analyzer. Whether it's a point-of-care analyzer like the IRMA or iStat, or a bench model like the ABL 800 Flex, it still needs calibration. There are multiple manufacturers of blood gas analyzers: Radiometer America, Roche Diagnostics, Instrumentation Laboratories known as IL, Nova Biomedical, and Siemens Healthcare Diagnostics, just to name a few. There are several more. I have used the IRMA and its calibration was contained inside the disposable cartridge. This is a picture of the iStat. The ABL 800, which I use at my current hospital, has an automatic time to calibration. Regardless, the basic steps are similar. For blood gas values, there are only 3 electrodes: O2, CO2, and pH. Other values are calculated. If you're interested in a little history, the electrochemical reduction of oxygen was discovered in 1897, and in the 1950s, Leland Clark developed the PO2 electrode and John Severinhaus developed the PCO2 electrode. In 1957, these two electrodes were combined into one apparatus, and in 1959, a third electrode was added to measure the pH. At that time, a guy named Forrest Bird, you have probably heard of him, offered to manufacture the CO2 electrodes and make them commercially available. This invention changed healthcare around the world and laid the foundation for the respiratory care profession. Calibration is fairly straightforward. You insert a liquid with a known pH and you adjust your equipment to match it. Calibration generally involves a low and a high point, and that is called a 2-point calibration. You insert a liquid with a low pH, like 6.8, and you adjust your machine as necessary. Then you repeat using another liquid with a higher pH. The same is done for gases, except calibration gases are used instead of a liquid. Gases are generally 5 and 10%. They won't use millimeters of mercury because that would fluctuate with the barometric pressure, but the percentage will stay the same. As an example, get the barometric pressure, deduct 47 for water vapor pressure, and then multiply that times the gas percentage. 760 minus 47 equals 713. 713 times 0.05 equals 35.65. So you insert your 5% gas and see if it matches 35.65. Otherwise, you make an adjustment. The calibration factor should be about 7 times the calibrating gas. In this example, 7 times 5 equals 35. If you were using the 10% gas, then it should be close to 70%. Remember this multiply times 7 rule, as it will come back around again in a little while. Quality control is a little different. You input substances into the machine with O2, CO2, and pH, and record the reading you get. You do not make changes to the machine. Usually acidotic, normal, and alkalotic controls are used. The results are then plotted on a graph called a Levy-Jennings chart. Here is an example of what a Levy-Jennings chart might look like. Using plus or minus 2 standard deviations as boundaries, after about 30 or so tests for each have been plotted, the results are evaluated to see how well the analyzer is functioning. In control, all values are within 2 standard deviations of the mean. Random error. Occasionally one point falls outside the standard 2 deviations we are looking for, and all the others are good. We don't worry about an occasional random error. A trend would be all values are within the 2 standard deviations, but are starting to trend up or down. A shift means all the values remain within the 2 standard deviation range, but the mean value has shifted up or down from where you started. Out of control, as the name implies, the data points are out of the 2 standard deviation range and your analyzer is out of control. You need to replace the electrode. Labs also do proficiency testing where samples with unknown values are sent to various labs with the same make and model of analyzer. These samples are run, and the labs are then able to compare their results with those of other labs. If a lab has multiple analyzers, they can run samples on the various machines and compare the results. If there are significant variances, then the reason for the discrepancies need to be identified. The best type of control for the PO2 electrode is called tonometry. A tonometer allows precision gas mixtures to be equilibrated with whole blood or buffer solutions. Once the buffering is complete, the sample is then run through the analyzer. The basic ABG information is pH, PCO2, PO2, bicarbonate, and base excess. As you can see from this list from the ABL 800 Flex operator manual, there are additional options available, but the usual add-ons are calcium and lactate. It is important to only choose the options that are ordered. If you are running calcium and lactate and billing the patient for these extra options, but don't have an order for them, then that could be considered false billing. The government frowns on false billing and has some super severe financial penalties for doing it. Electrolytes are the ionized or ionizable constituents of a living cell, blood, or other organic matter. Metabolites are substances made or used when the body breaks down food, drugs, or chemicals, or even its own tissues, for example, fat or muscle tissue. We have verified our analyzers, calibrated, and we've run our sample. Awesome job. Now what? Are we finished? Nope. Now we have to interpret the results. We're going to begin with some basic information which you are probably already familiar with, but we have to start somewhere. I like to begin at the beginning. In order to interpret a blood gas, you must understand acidosis and alkalosis. Acidosis is an increase in hydrogen ion production and a corresponding increase in concentration in the plasma, or extracellular fluid. Alkalosis is the opposite, a decrease in hydrogen ion concentration in the plasma. The formula used to figure the pH is the negative log of the hydrogen ion concentration. This means there is an inverse relationship between the pH and hydrogen ions. The more hydrogen ions in the blood, the lower the pH. The fewer hydrogen ions, the higher the pH. Where do all these hydrogen ions come from? I'll answer that in a minute, but first there are 2 additional molecules you need to consider when thinking about pH, and that is CO2 and bicarbonate. Through cellular metabolism, our body is constantly producing CO2 and water. With the help of an enzyme called carbonic anhydrase, this is converted to carbonic acid. Remember, an enzyme is a substance that acts as a catalyst in a living organism, regulating the rate at which chemical reactions proceed without the reaction being altered in the process. Without enzymes, many of these reactions would be so slow that they would be at an imperceptible rate. In fact, without enzymes, you wouldn't even be able to digest food. So, CO2 and water combine to form carbonic acid, which is a weak acid. It dissociates or breaks apart into bicarbonate and hydrogen ions. By the way, This reaction goes both ways, hence the arrows pointing both directions. In fact, most of the CO2 in your body is stored as bicarbonate. Total CO2, you'll see this on the patient's chemistry panel, is normally around 25 millimoles per liter and is calculated by taking the bicarbonate and adding 0.03 times the CO2. For academic purposes, you should know that the pH calculations are based on the Henderson-Hasselbalch equation shown here. Now that looks like a lot of math that we aren't going to get into, but you should know the pH scale is from 0 to 14. The lower the number, the more acidic, and the higher the more alkaline. Us humans like to live at a pH of 7.4, which is considered neutral. For our discussion here, we will use a simplified version. pH equals bicarb over PCO2. If the bicarb is constant, the higher the PCO2, the lower the pH. The lower the PCO2, the higher the pH. Before you can determine abnormal, you have to know normal. Here are the normal ranges for blood gas values. pH 7.35 to 7.45, PCO2 35 to 45, PO2 is 80 to 100, bicarb is 24 plus or minus 2, and base excess is minus 2 to plus 2 milliequivalents per liter. When you're reporting values, that is also the order they should be reported in. pH of 7.4 is considered neutral, below 7.4, but really below 7.35 is acidotic. Above 7.40, but really above 7.45 is alkalotic. A rise in CO2 will cause the pH to go down and a decrease will cause it to go up. An increase in bicarbonate will cause the pH to rise and a decrease in bicarbonate will cause the pH to fall. As a side note, if you were reporting a blood gas result to a doc, would you say, "Here are the patient's blood gases," or use a singular, "Here is the blood gas results"? There are multiple gases involved. Now that we have reviewed normal, what is super abnormal? These values are what I call the death zone. pH of less than 6.8 or greater than 7.8. Either of these states will interfere with cell function and lead to death if left uncorrected. Now I need to go over some terminology just for completeness. Respiratory acidosis occurs when ventilation is inadequate and CO2 rises or builds up. The pH is less than 7.35 and the CO2 is greater than 45. It could also be called acute ventilatory failure. This extra CO2 now combines with water and forms carbonic acid, causing acidosis. Ventilatory failure can be acute or chronic. The chronic version may be asymptomatic, but the acute version can lead to headache, confusion, drowsiness, decrease in contraction force of the heart, decreased vascular response to catecholamines, and a diminished response to some medications. This can be caused by ventilation chain defects caused by CNS depression, commonly caused by medications, or perhaps a neuromuscular disorder. These would be classified as disordered control of breathing. Your brain isn't communicating to your body to breathe. It can also be caused by acute respiratory failure. You can breathe, maybe 50 times a minute, but you still can't keep up with demand. This might be caused by pulmonary disease or an increased CO2 production. Increased CO2 production can be caused by sepsis, fever, overfeeding calories, and of course other causes. By the way, the causative examples I am giving are not meant to be an all-inclusive list, just a representative list. Looking back at the simplified equation I used, pH equals bicarb over PCO2, 24 over 55 will give you a reduced pH. As I mentioned, respiratory failure can be acute or chronic, as is common in COPD. Chronic respiratory failure is where you have an elevated CO2, an elevated bicarb, and a normal pH. You can also have what is called acute on chronic respiratory failure. This means the patient normally has a compensated respiratory acidosis, but due to an acute situation, the CO2 has risen beyond its normally elevated state and has dropped the pH back into an acidotic situation. This is very common in COPD exacerbation, where the patient has a normally compensated elevated PCO2, but due to a lung infection, the CO2 rises even further. Acute on chronic is probably one of the hardest types for RT students to wrap their heads around. Respiratory alkalosis occurs as a result of hyperventilation. It is defined as a PCO2 less than 35 and a pH greater than 7.45. This can be caused by anxiety, fear, pain, hypoxemia, hypoxia, increased metabolic demands like fever, sepsis, pregnancy. Some medications and central nervous system disorders can act as a respiratory stimulant. Of course, it can also occur as a result of ventilator mismanagement. Using the simplified equation again, pH equals bicarb over PCO2, 24 over 25 would give you a higher pH. Some of the signs and symptoms of respiratory alkalosis include numbness, tingling, confusion, blurred vision, muscle spasms of the arms and legs, diaphoresis, dysrhythmias, palpitations, and dry mouth. Of note, neurologic and cardiac effects usually only occur at a pH of 7.55 or greater. Metabolic acidosis is caused by a deficit of base in the blood plasma or excess of acids other than CO2. It is defined as a bicarbonate level less than 22 and a pH less than 7.35. Once again, using our modified formula, pH equals bicarb over PCO2, 16 over 40 would give you a lower pH. A common cause to lose base is diarrhea, and for increased acid are renal failure, DKA, anaerobic metabolism, starvation, and salicylate ingestion, otherwise known as aspirin. Common signs and symptoms are headache, confusion, coma, dysrhythmias, Kussmaul breathing, as seen with DKA, and nausea and vomiting. If your body has too much acid, perhaps vomiting is a natural way to get rid of some of it in an effort to restore the pH back towards normal. The first time I had a colonoscopy done, of course, I had to drink that awful tasting stuff to make me have severe diarrhea to clear out my colon for the procedure. After several hours of that, I started vomiting. I realized my body's pH must be getting whacked out as it is vomiting out acid to try and compensate. Not a fun night. Metabolic alkalosis is caused by an increase of base in the blood plasma or decrease of acids other than CO2. Metabolic alkalosis is defined as a bicarbonate level greater than 26 with a pH greater than 7.45. Again, using our modified formula, 38 over 40 would give you a higher pH. Some causes are excessive use of antacids or bicarbonate, gastric suctioning due to loss of acid, protracted vomiting for the same reason, and excessive use of diuretics. It can cause respiratory depression, dizziness, seizures, coma, muscle twitching, cramps, nausea, and vomiting. Metabolic alkalosis can be difficult to treat, but bicarbonate excretion through the kidneys can be stimulated with acetazolamide known as Diamox. In severe cases, perhaps IV acid administration can be considered. You can have mixed respiratory and metabolic conditions. This is where the CO2 and bicarb are going in opposite directions, with one up and one down. As an example, you might see this post-ROSC after a code. You probably would find a high CO2 and a low bicarb due to lactic acid buffering, alcoholic ketoacidosis, severe asthma with lactic acidosis from hypoxemia, liver disease, where you'd have respiratory alkalosis plus metabolic alkalosis from diuretics for ascites or vomiting, just to name a few. You can also classify the levels of hypoxemia based on the PO2 as mild, moderate, and severe. 80 to 100 millimeters of mercury would be normal, 60 to 79 mild, 40 to 59 moderate, and less than 40 would be severe. Causes for hypoxemia include low inspired FiO2, hypoventilation, diffusion defect, increased consumption, and VQ mismatch. And this is a good spot to bring up the oxyhemoglobin dissociation curve. As you should know, most of the oxygen, around 98%, is carried in the blood bound to hemoglobin. This graph represents this binding. The first thing you should notice is the graph flattens at the top. Once the PO2 is in the 90s, there isn't a lot of O2 binding to be gained by increasing the FiO2. As the graph shifts to the left, the hemoglobin will grab onto the oxygen a lot easier, known as increased affinity, but doesn't want to release it. So you end up with decreased tissue oxygenation. A shift to the right causes a decreased affinity for oxygen, so a lower saturation, but the hemoglobin releases the oxygen easier to the tissues. An easy way to remember this is hot acid is right. If the patient has a temperature or is acidotic, that will cause a right shift. The opposite causes a left shift. Also, decreased 2,3-diphosphoglycerate, known as DPG, which is associated with stored blood, will cause a left shift. What does this mean? The bottom line on this is it is better to be acidotic than alkalotic. If the patient is on a vent and they are alkalotic, you need to address the situation immediately if possible. Since we are discussing saturation, we might as well cover total oxygen content. This is an important concept for healthcare practitioners, especially respiratory therapists. Around 98% of the oxygen is carried on the hemoglobin, with the additional 2% dissolved in the plasma, the P(a)O2. The formula for the CaO2 is 1.34 times the hemoglobin times the saturation plus the PaO2 times 0.003. The 1.34 is the amount of oxygen that each gram of hemoglobin can carry and has been calculated to be between 1.32 and 1.39, depending on the circumstances. Where does the 0.003 come from? Henry's gas law states that the amount of dissolved oxygen is proportional to the partial pressure of oxygen and its solubility coefficient. Therefore, it is calculated from the arterial oxygen tension, the PaO2, and the solubility coefficient of oxygen, the SOLO2. In other words, at an arterial PO2 of 100 millimeters of mercury, 100 milliliters of arterial blood contains 0.31 milliliters of dissolved oxygen. That is where the 0.003 in the formula comes from. Now, I hope you recognize that any number around 100 multiplied by 0.003 is almost nothing. For practical purposes, that part can be ignored. While PO2 is important, hemoglobin and saturation are far more so. A good normal arterial oxygen content is in the high teens, 17, 18, 19. Normal is around 20 volumes percent, also known as milliliters per deciliter. Venous saturation is normally around 75%, which means you used about 25% of the oxygen. Therefore, a normal venous content is 75% of the arterial content, or in the low teens, 13, 14, 15. Venous gases look like bad arterial gases. This also means a normal arterial to venous oxygen content difference is 4 to 5 volumes percent. This can be used in a modified Fick equation to calculate cardiac output and indicates cardiac function. When we get a fresh cabbage patient from the OR in our ICU, one of the first things we do is arterial and venous gases, and that is what they are looking for. Arterial gases go with the lungs and venous gases go with the heart. Although I will save digging into that subject for a future lecture on hemodynamics. Pop quiz. Where do you draw a mixed venous gas from, an artery or a vein, and why? The answer is the pulmonary artery. Remember, any vessel carrying blood that flows away from the heart is called an artery, and if it flows towards the heart, it is a vein. It doesn't matter if the blood is oxygenated or deoxygenated. The pulmonary artery leaves the right ventricle and goes towards the lungs, taking with it deoxygenated blood. Coming up, we are going to interpret a few ABGs. But as a quick rule of thumb, if both the CO2 and bicarb are going in the same direction, then one is compensating for the other. If they are moving in opposite directions, one up and one down, then they are working together to create the problem. If the pH and bicarb are moving in the same direction, there is a metabolic component, and if the CO2 and pH are moving in opposite directions, then there is a respiratory component. How do you tell which is causing the problem and which is compensating for it? Your body won't overcompensate. Look at the pH and use 7.4 as the midline. If the pH is low, then whichever would cause a low pH, high CO2 or low bicarb is the culprit. If the pH is high, then whichever would cause that, low CO2 or high bicarb, is the troublemaker. Before we start looking at some ABGs, let's go over one more item. Base excess is often a confusing concept, and I'm going to try and shed some light on it. This refers to the metabolic component of the acid-base balance. As the name implies, this value refers to extra base, although it can also reflect a base deficit in the blood. It is a calculated value derived from pH and PCO2. It is the amount of acid required to restore the pH to normal at a PCO2 of 40. With metabolic alkalosis, it is a positive number, and with metabolic acidosis, it decreases or becomes a more negative number because you would have to take away acid since you are short on base. This can be a weird concept to think about, and its clinical significance is controversial. Regardless of your position on this, remember that base excess will move approximately 6 milliequivalents per liter for each pH change of 0.1 that is unaccounted for by a change in PCO2. There are different schools of thought when it comes to ABG interpretation. Most people look at the pH first. However, I am a respiratory therapist and I am going to look at CO2 first. Is the patient ventilating? Don't overthink this. It is a simple yes or no question. If the CO2 is high, they aren't ventilating. If it is within normal range or low, then they are ventilating. They might be overventilating, but they are still ventilating. Once I determine that, I look at the pH. Is the pH normal, high, or low? As I previously mentioned, patients can have a high CO2 and a normal pH due to kidney compensation. That would indicate a chronic situation as the kidneys take hours to days for compensation. If one of these conditions exists, high-low CO2 and high-low bicarbonate, yet the pH is normal, that would be called compensated. If compensation has started but the pH is not yet within normal range, that is called partially compensated. Here are a few examples: 7.30, 50, 65, 24. CO2 is high, bicarb is normal, pH is down. This would be classified as uncompensated respiratory acidosis. 7.30, 50, 65, 28. CO2 is high, bicarb is up, pH is down. This would be classified as partially compensated respiratory acidosis. 7.36, 54, 65, 30. CO2 is high, bicarb is high, pH is normal. This would be classified as compensated respiratory acidosis as the pH has been moved back into normal range. You know that it is a respiratory problem as the pH is on the acid side of 7.4. 7.49, 30, 65, 24. CO2 is down, bicarb is normal, pH is up. This would be classified as respiratory alkalosis. 7.42, 30, 65, 18. CO2 is down, bicarb is down, pH is normal. This would be classified as compensated respiratory alkalosis. 7.30, 28, 80, 19. CO2 is down, bicarb is down, pH is down. This would be classified as partially compensated metabolic acidosis. Now it's time to put information into action and interpret a few blood gases. Example number 1. 58-year-old male, he's 5 foot 9 inches tall, 295 pounds, has stroke-like symptoms with a history of CVA, diabetes, and obesity. He's on ACVC, rate of 16, tidal volume of 450, PEEP of 5, FiO2 50%. 7.37, 47.1, 72.4, and 26.4 with a base excess of 1.3. This is compensated respiratory acidosis. Example number 2. 22-year-old male, he's 6 foot 1, 146 pounds. Came in with altered mental status and acute encephalopathy. Has a history of asthma. He's on ACVC 16, 400, 5, FiO2 50%. Blood gas is 7.20, 61, 254, 22.7 with a base excess of 5.7. Uncompensated respiratory acidosis. And yes, someone needs to fix this ventilator. Example number 3. 64-year-old male. He's 5 foot 7, 160 pounds. Came in with septic. Encountered respiratory failure, failed BiPAP, and got intubated. He's on ACVC, rate of 14, tidal volume 450, PEEP of 5, FiO2 40%. Blood gases 7.42, 44.5, 79.4, 28.4 with a base excess of 4.0. Compensated metabolic alkalosis. Example number 4. 46-year-old female, 5 foot 0, 130 pounds, shortness of breath times 8 days. Came in with COVID. She's on ACPC, frequency of 26. PI of 23, TI 1.0, PEEP of 5, FiO2 100%. Blood gas results were 7.29, 62.8, 53.1, 29. Base excess 1.6. Partially compensated respiratory acidosis. Example number 5. 44-year-old male, he's 5 foot 6, 223 pounds. Came in with urinary retention and lower extremity edema. History of CHF, he's got an ejection fraction of 20 to 25%. Hypertension, OSA, obesity, and he's pre-diabetic. He's on BiPAP 24/5 and 40%. Blood gas results were 7.54, 43.1, 96.8, 37.1 with a base excess of 12.8. Uncompensated metabolic alkalosis. To quote my friend Joe Lewis, famous for being the respiratory coach on YouTube, average is easy, don't be it. The average respiratory therapist can interpret the ABGs that we just did. it's time to step it up a bit and think about some advanced ABG concepts. Let's move on to anion gap. The blood will remain neutrally charged, meaning the number of positively charged ions equals the negatively charged ions. Cations are positively charged ions and anions are negatively charged ions. There is normally a gap between the measured cations and unmeasured anions, and this is known as the anion gap. Even though we don't measure these ions, we can use a calculation involving some of the major plasma ions we do measure to figure out the difference between them. The formula is sodium plus potassium minus the chloride plus bicarb. However, potassium is usually omitted, so you could just do sodium minus the chlorine plus bicarb. A normal anion gap is 3 to 11 milliequivalents per liter, although some older tests may indicate 8 to 16. In the next lesson, you will watch a 3-minute YouTube video by Dr. Mimi Lamb. She does an excellent job of illustrating this concept. NAGMA stands for Normal Anion Gap Metabolic Acidosis, although I have seen that term used as non-anion gap metabolic acidosis. Of course, both mean the same thing. This indicates a fall in bicarbonate through loss. There is a mnemonic available to help you remember the causes. A, B, C, D. A is for Addison's disease, which is also known as adrenal insufficiency. This causes your adrenal glands, which are located just above your kidneys, to produce too little cortisol or aldosterone. B is for bicarbonate, commonly lost through diarrhea or renal tubular acidosis. And C is for chloride, actually excessive chloride, and would be called hyperkalemic metabolic acidosis. Perhaps the patient was given excessive amounts of normal saline IV fluids. D is for drugs like acetazolamide, also known as Diamox, or some other carbonic anhydrase inhibitors. HAGMA stands for high anion gap metabolic acidosis. A high anion gap indicates retained organic acids in the blood and could indicate acidosis from dehydration, kidney disease, diabetes, lactate, and of course other causes. These extra acids can be either produced by the body or ingested, such as with methanol or ethylene glycol poisoning. There are several mnemonics available to help you remember causes for HAGMA. The simple one is LTKR, lactate, toxins, ketones, and renal failure. The next one is called CARMEL, ketones, aspirin, renal failure, methanol, ethylene glycol, and lactate. Then there is cat mud piles, which is the exhaustive list. Cyanide poisoning, and that would also include carbon monoxide. Alcoholic ketoacidosis, toluene, methanol, metformin, and of course metformin is used to treat hyperglycemia with type 2 diabetes, uremia, diabetic ketoacidosis, paracetamol, iron, isoniazid, lactate, ethanol, ethylene glycol, and salicylate. Here's a new mnemonic called Goldmark, which is recommended to replace mud piles. Glycols, oxoproline, which is associated with chronic acetaminophen or Tylenol use. L for lactate, and then there's D-lactate, methanol, aspirin, renal failure, and ketoacidosis. Of course, there are others, like Kusmale is another one, Kusmale. Most of them just rearrange all these to different words, so just find one that you can remember and stick with it. A low gap could indicate low albumin, which may indicate kidney problems, heart disease, or some types of cancer. After running a gas through the analyzer, I always check to make sure it transferred over into our EMR system. It only takes a few seconds to click on the chem panel and figure out the anion gap. At my hospital, the anion gap is listed as part of the chem panel, so no math is needed. It can give you some insight into what's going on with the patient and make you look a lot smarter when you provide the physician with this information. The next couple of slides, we're going to be calculating the anion gap. In our example number 1 patient, sodium was 141, potassium 3.4, chlorine was 107, and bicarb 26.4. Remember I said you can ignore the potassium, so sodium of 141 minus the chlorine of 107 plus the bicarb of 26.4 gives you a result of 7.6. Example number 2, sodium 140 minus the chlorine of 109 plus the bicarb of 22.7 gives you a gap of 8.3. Example number 3, sodium 130, chlorine 94, bicarb 22.5 gives you a gap of 13.5. Now that we have moved up from the average respiratory therapist, let's take it up a notch further. If you have a high anion gap, then you should also figure out the delta gap. It might also be called the delta ratio or the delta-delta gradient. A delta ratio equals the change in anion gap divided by the change in bicarbonate. The delta-delta is calculated by taking the anion gap minus the expected anion gap divided by 24 minus bicarb. The normal anion gap is assumed to be 12 and the normal bicarb is assumed to be 24. Going back to example 3, let's take a look at the delta-delta. 13.5 minus 12 divided by 24 minus 22.5. This gives you 1.5 divided by 1.5 with a quotient of 1. So what does this mean? 0.4 equals a normal anion gap metabolic acidosis. 0.4 to 0.8 is a mixed high and normal anion gap acidosis. 0.8 to 1 purely due to a high anion gap metabolic acidosis. 1.0 to 2 still purely a high anion gap metabolic acidosis, and over 2.0 high anion gap acidosis with pre-existing metabolic alkalosis, or high bicarb. One should use this information with caution. There are limitations to assumptions made with these calculations. Also, these calculations are twice removed from the actual blood gas analysis, so errors can be exacerbated. It just gives you a clue to look further, dig deeper into the patient's problem. Most therapists probably look at metabolic issues as not my problem. Report the values and move on. Be better than that. Let's revisit the concept of increased hydrogen ions for a minute. As the hydrogen ions build up in the plasma, in an effort to neutralize this, they will start shifting into the cells. The cells want to stay neutrally charged, meaning an equal number of positive and negative particles, so they start dumping out other positively charged particles, primarily potassium. This will cause the potassium levels in the plasma to rise. However, the potassium levels should remain within normal limits, although high normal, unless there are other contributing factors. Chronic respiratory failure has no effect on potassium. Let's recap what we have accomplished so far. We calibrated our blood gas machine, we verified we had a correct order and the correct patient. We drew the gas, being careful to avoid pre-analytical errors, ran the gas and interpreted the results. Now what? Let's move on to everyone's favorite part of the show, medical math. There is the swag method, scientific wild-assed guess, to ventilation management. Turn some knobs, get a new gas, see what happened. Repeat as necessary. Not the best idea. Most of you are familiar with this equation. Current minute ventilation times current CO2 equals future ventilation times future CO2. This formula allows you to calculate changes needed to minute ventilation in order to obtain a desired CO2. Since minute ventilation is rate times volume, unless you are changing both the tidal volume and the rate, you can just use current respiratory rate times CO2 equals future respiratory rate times CO2, or current tidal volume times CO2 equals future tidal volume times CO2. Whichever value is remaining constant, you can leave out of the equation. Before keeping your tidal volume constant, you should verify you have a correct tidal volume. There are several formulas for ideal body weight. This is the one I use. Predicted body weight in kilograms. Males is 50 plus 2.3 per inch above 60, and females is 45.5 plus 2.3 per inch above 60. Then you should ventilate using 6 to 8 milliliters per kilogram, but I like to stick closer to 6. Of course, you can deviate from this if the situation dictates. And this is still really only part of the equation. If you were my Uber driver and I called for a ride to the airport, one of the first things you'd need to know is my address. You have to know where you want to go. Same rule applies here. You have to know what you want the CO2 to be. Who can tell me how much CO2 does it take to move the pH by 0.1? There is a slight variation between references, but I use pH 0.1 equals 12 pCO2. Another reference said pH 0.1 equals 10 CO2. Regardless, the first thing to do is figure out how much of a pH change is desired. Let's go back to our previous example number 2. I mentioned earlier someone needs to fix this vent. Let's fix it. Current blood gas is 7.20, 61, 254, and 22.7. Let's check his predicted body weight. He's 6 foot 1 inch, so that equals 73 inches. 73 minus 60 equals 13. 50 plus 2.3 times 13 equals 50 plus 29.9, and that equals 79.9. I will round that off to 80. Let's check his tidal volume range. So 80 times 6 is 480, and 80 times 8 is 640. So his tidal volume range is 480 to 640. We need to move the pH to at least 7.35. So that is a change of 0.15. And remember, I said I use pH of 0.1 equals 12 CO2. So 12 times 1.5 would be 18. We need to move the CO2 by 18. So our desired CO2 is currently 61 minus 18 equals 43. Minute ventilation of 6,400 times the current CO2 of 61 equals 480, which is our desired tidal volume, times respiratory rate times 43. So 390,400 equals 20,640 times your new rate. Divide that out and you get a rate of 18.9. So you could change it to about 19 would be fine. We fixed ventilation, now it's time to fix oxygenation. But first, it's another gas law. Dalton's law, also called Dalton's law of partial pressures, states that in a mixture of non-reacting gases, the total pressure exerted is equal to the sum of the partial pressures of the individual gases. This was observed by John Dalton in 1801 and published in 1802, so it's been around a while. Here's what this means. Measure the individual gas pressures and then add them all together to get the total. If the pressure of gas number 1 is 0.4 atmospheres and gas number 2 is 0.6 atmospheres, then you have a total of 1.0 atmospheres. Fairly simple concept, but important to think about when you calculate the alveolar air equation. Another way to think about this is there are only so many marbles in a jar. Say 70 blue, 20 green, 10 red. If you want to put in more green ones, then you'll have to remove some of the others. When you push more oxygen into a patient, you are displacing nitrogen. Let's take a look at the alveolar air equation. One way to think about this equation is it's Dalton's law backwards. We're taking the total pressure and subtracting known gas pressures to get the answer. The barometric pressure is the total gas pressure. That number is the jar of gases. We will use 760 for this example, but you should be able to get this value from your blood gas machine or from some device in the lab. You subtract the water vapor pressure from the total, which is 47 and is a constant, and then multiply that by the FiO2. There is one more gas in the lungs we have to deal with, and that's CO2. Divide the CO2 by the respiratory quotient of 0.8, or multiply times 1.25. These are mathematically the same. However, I find multiplying is generally easier. So your P big AO2, which is the amount of available oxygen in the lungs, equals the FiO2 times the barometric pressure minus 47 and subtract the CO2 times 1.25. There are a few shortcuts for this if you need something quick and don't mind a close estimate. You can take 7 times the FiO2 minus the CO2 plus 10. Another quick shortcut is the P big AO2 on an FiO2 of 50% should be around 300. From there, you can just adjust 300 by the change in FiO2 percentage. As an example, 55% would be 300 plus an extra 5%, or 315. There is a small decrease in the amount of oxygen that actually gets transferred into the blood from the lungs. This is known as the A to A gradient. The normal gradient is around 5 for a person breathing room air. If your P big AO2 is 100, then you would expect your P little AO2 to be around 95. As oxygenation gets worse, that difference will get bigger, and it can be used to estimate the shunt percentage. A good rule of thumb is the A to A gradient should be less than 100, even on an FiO2 of 1.0. Or the A to A gradient should be less than the FiO2. The patient's A to A gradient probably isn't going to change that much in the next 5 minutes, so you can use various math formulas to calculate PaO2 changes based upon FiO2 changes. Before we do that, I want to take a minute and show you why a CO2 retainer's PO2 is in the 60s. Let's take a quick look at a chronic CO2 retainer's gas. You have probably heard of patients being in the 60-60 club, meaning both their CO2 and PO2 are chronically in the 60s. Let's say his CO2 is 65. What would his normal PO2 be? You can use the alveolar air equation to find out. We'll assume your hospital is at sea level, but in reality it probably isn't, and the barometric pressure is less than 760. Or we'll use 0.21, which is room air, 21%, times 760 minus 47, minus 65 times 1.25. Gives us 0.21 times 713 minus 81.25 is 149.73 minus 81.25. I'm just going to round all that off to 150 minus 81. So that leaves us with 69. And we will assume this guy's got perfect lungs, but although we know it's not true. And we're going to assume a normal A to A gradient of 5. So 69 minus 5 gives you the best PO2 this guy could even get is 64. That is without supplemental oxygen. Now let's look at ways to estimate PaO2 changes based upon FiO2 changes. The first formula looks very similar to the ventilation formula we used earlier. The new FiO2 would equal the desired PaO2 times the known FiO2 divided by the known PaO2. Another formula is the A to A ratio. We can use it to predict a PO2 that will result from an FiO2 change. We can use it also to find an FiO2 to produce a given PO2. Here I'm going to show you how to find the PO2 from an FiO2 change. And this really works, but only when the FiO2 is the only new adjustment. Predicting PaO2 for a changed FiO2. So we're going to take the current ABG, FiO2 of 0.6, PaO2 of 50, CO2 of 30. Increasing the FiO2 to 0.7 will produce what PO2? So you use the alveolar air equation to find the A to A ratio. So first you're going to get the alveolar air equation, which is P big AO2, so take 0.6 times 713 minus 30, which is the CO2, times 1.25, that gives you 390. Divide 50, which is your P little AO2, that's the oxygen in the blood, divide that by 390, and that gives you an A to A ratio of 0.13. Increasing the FiO2 to 70% or 0.7 will produce what PaO2? Recalculate the alveolar air equation using the FiO2 of 0.7. So that's 0.7 times 713 minus 30 times 1.25 equals 462. Now you take 462 and multiply that times the original A to A ratio. So that's 0.13 times 462 equals 60. Now both of these are a lot of math. Let's look at an easier way to do this, and that's using the PF ratio. You should be familiar with this formula as an adjunct for determining acute lung injury and ARDS. At my hospital, we use the ABL 800 Flex analyzer, and it is automatically given as part of the blood gas report. I wouldn't be surprised if other machines also supply this value. If you aren't looking at the PF ratio, you need to be. The normal, as you will see, will be 95 divided by 0.21, which is FiO2 of room air, or 452. As defined, acute lung injury involves a ratio of less than 300, and for ARDS it is less than 200. There are some updated Berlin definitions if you are interested in ALI ARDS, although this index does have its disadvantages. First, it does change with the FiO2, and secondly, it does not take lung mechanics into account. The PF ratio is basically simplified A to A ratio. The P and the little a are the exact same value, and if the only change you are making is O2, then all of the other values for the big A remain fairly constant. The CO2 may change a little, but unless you're moving the patient up or down a mountain, the atmospheric pressure should stay constant. Although I do wonder if there's a bad storm outside and the barometric pressure is dropping, how does that affect my patient's oxygenation? Here is the PF ratio for our patient. 254 divided by 0.5 equals 508. You can use the PF ratio to estimate FiO2 changes needed to get a desired PaO2. Again, the patient's A to A gradient is not going to change, So you just divide the new desired PaO2 by the original PF ratio. In this example, it comes out close to 20, so drop the FiO2 to 21%. These do have some limitations. This isn't an exact science, but should get you close, and once you hit an FiO2 of 60 going up, you should be increasing PEEP before advancing the oxygen levels. On the way down, we usually stop around 55 to 60% and then start reducing the PEEP. Of course, then you have to consider peak inspiratory pressures, plateau pressures, driving pressures, pressure volume curves, optimal PEEP, all kinds of things come into play, but that is another lecture for a different day. Another index exists for patients who are on continuous mechanical ventilation, the oxygenation index, or OI. Although it has been primarily used for PD patients, the OI has been validated for application to adults. I think this could be very useful in monitoring the status of patients with severe conditions such as ARDS. As you see by this equation, the oxygen index equals the FiO2 times the mean airway pressure divided by the arterial PO2. A value less than 5 is considered very good, between 10 and 20 is medium, and greater than 25 is just awful. In some centers, this value or greater would cause clinicians to consider ECMO for their pediatric patients. The primary advantage of the OI is that it takes lung mechanics into account by including the mean airway pressure in its calculation. The OI has strong prognostic value. The greater OI implies a greater risk for mortality. We know that the respiratory system will compensate for metabolic issues, but how do you know if it's a combined issue? Well, there's a calculation that allows you to assess whether it's pure metabolic acidosis or if there's also a respiratory system component. This is called the Winter's formula, and it is a calculation of predicted PaCO2 for a particular bicarb level. Then there's the VD to VT ratio. This is arterial CO2 minus end-tidal CO2 divided by arterial CO2. Basically, CO2 minus CO2 divided by more CO2. Normal end-tidal CO2, also known as PET CO2, is 5 to 10 less than blood gas CO2, or the pCO2, due to dead space mixing when we exhale. Normal dead space is 25 to 40%, up to 60% on a ventilator because we are ventilating areas that aren't normally perfused. Primary cause of acute increased dead space is PE. Here is an example of the math involved. 45 minus 35 equals 10. 10 divided by 45 equals 22. If you have a normal pCO2 and normal end-tidal CO2, you will have normal dead space. Waveform capnography is best, as the shape of the waves can give you a clue as to what is happening with the patient. Lastly, I want to make sure everyone is aware of how to change BiPAP settings based on ABGs. Tidal volume is created by the difference between the IPAP and EPAP. In the first example, the pH is low, CO2 is high, and O2 is fine. Simply increase the IPAP. However, in the second example, the pH is low, the CO2 is high, but the O2 is also high. Instead of raising the IPAP, the best thing to do is lower the EPAP. This still widens the difference between the IPAP and EPAP, but will also lower the O2 at the same time. One last thing about BiPAP, please be sure to set your alarms correctly. Having a backup rate of 6 and alarm set at 4 means your alarm will probably never go off. Let's summarize and review for just a minute. We talked about ABG analyzer quality and control, avoidance of pre-analytical errors, normal ABG values, ABG interpretation, NI and gap, delta delta, and finished up with medical math. Here are some of the references I used to create this course. This brings us to everyone's favorite slide, the end. I hope I was able to teach you at least one or two new things that you can use in your practice. Looking forward, We are the ventilation and oxygenation superheroes of the hospital. Get really good at it. Where I work, we manage the ventilators and tell the docs what we are doing, not the other way around. You should be doing the same. There's a link on the right side of the main course page under course materials to a very nice free resource from Radiometer America called the Acute Care Testing Handbook. You should check it out. Also, if you are interested, on this website, Joe Lewis, the respiratory coach from YouTube, has an advanced ABG interpretation course. You should keep an eye out for it.